I'd like to take this opportunity to thank Lori and Sandy and Anne Louise and their mother for making this possible today. And I have the wonderful pleasure to talk about hope, which this is the theme of the day, with dealing with pancreatic cancer. And hopefully we'll give you some tips on how to navigate through the system, how the McCain Centre works, and how we move forward. Just to begin with, I have a disclosure slide as well. I've been a nurse for many, many years, and actually I started nursing. I'm a surgical oncology nurse to begin with, starting in 1990, and I worked with Dr. Steve Gallinger at Mount Sinai Hospital when he had finished his fellowship and took on his first position at Mount Sinai. I began working in the McCain Centre at Princess Margaret in March of this year and have taken over for Alison Knoll, the original clinical nurse specialist who built the program and then took on a new leadership position. However, like I said, I've been a surgical oncology nurse for many, many years. And prior to coming to Princess Margaret, I worked at Sunnybrook and the Odette Cancer Centre and worked with the 3 surgeons there on the inpatient. And I worked with patients that were going through the surgery, the Whipple procedure or pancreatic surgical workup. I fully embrace the concept of hope. And I love the concept of hope, and we're going to talk about it. And I'm going to try to weave that theme throughout what I talk about today. And I also have a lot of experience of bridging the gap between cancer treatment, whether it's surgery, medical oncology, or radiation, with the philosophies of psychosocial care and palliative care services. And this is important, and these services, as we're going to talk about, are going to sustain your hope and maintain it and get you through some of the challenging times that do happen during this journey. But also, I'm a realist, so we have to plan as well. So there's hope and there's realism. I thought I'd start with, and I've done this 5 years ago, and things have changed. There is a Google exercise. You just go to Google and you put pancreas cancer in it, and what happens? And sometimes that information, when you're first hearing of a loved one having been either worked up for it or has been diagnosed with pancreas cancer, can be quite daunting. So these are the first 5 pages that come up, and a few words right on the first screen. Pancreatic cancer is highly lethal. Pancreatic cancer is aggressive with few symptoms until the cancer is advanced. The symptoms that are specific enough to suspect pancreas cancer often do not appear until the disease is already in advanced stage. Gain knowledge, find hope. You are not alone. Wonder where that came from. And pancreatic cancer often has a poor prognosis, even when diagnosed early. However, I want to temper this, and this is not from a scientific. So it's been almost 25 years that I've been working with patients and families and healthcare teams in this area. And it's true that probably survival has doubled, not based on research, just from experience of working with this population, that 3 to 6 months was probably what patients got after being diagnosed. But there are many, many, many patients and families living and enjoying their life for months to 12 to 24 months and beyond after being treated for pancreas cancer. So I found this on the internet, and I thought this was kind of neat, is that we cure sometimes, we hope to cure more, and there's always that hope. We relieve often, and a lot of the treatments that are offered at major cancer centers throughout Canada relieve the symptoms related to pancreas cancer, and we as an interprofessional team comfort always. So a little bit about the background of the McCain Centre for Pancreas Cancer. Mr. Wallace McCain, I didn't have the pleasure of meeting him, was diagnosed with pancreas cancer in 2010, and he was treated at Princess Margaret Cancer Centre. He survived 14 months post-diagnosis, and he donated quite a significant amount to Princess Margaret to establish the center that I work in. And our overall goal is to improve the diagnostic and total experience for patients and their families. So what's the difference in what we do? And I want to temper a statement made is that when we get a referral to our center, we rapidly look at it and start the journey to getting a diagnosis and or the patient on treatment. So the referrals are triaged separately than the general gastrointestinal referrals at Princess Margaret. Contact is made with patients and families within 24 to 48 hours saying, we've got your referral, it's being looked at by a team, and we will be in contact with you. The initial assessment is usually completed within 5 to 7 working days. And what's unique about our center is we do not need a tissue diagnosis. So you can come to the McCain on a referral and not have a biopsy, and we will work with our teams within in the downtown Toronto area in working out the biopsy and getting the diagnostic. And this is an important part because some of the research that I'm going to just speak to just in general, there are research studies attached to biopsies that are of benefit to patients and families. So coming into the center without a tissue diagnosis is not necessarily needed, and there's a potential to participate in research. Their supportive care services are available at the beginning and at any point during the journey. We have a social worker, a dietitian, and the psychosocial supportive care team and palliative care, which I will speak of. And what we do very well at Princess Margaret is research coordination. And this slide is courtesy of Anna Dodd, our research coordinator, and Bernadette Southwood, or Bernie, is the clinical trials nurse that works with our team. And I'm not going to speak to all of these, but in general, there's a lot of research that you potentially can be enrolled in or learn about, and Anna helps figure out through all these circles which ones are of benefit for you, and then in a very person-centered way decides when to introduce what at what point time during your journey. So in average, and this has been talked about already, is about the 20% that go the surgical route. And I just want to comment or just say, if a surgeon can operate, they will offer you surgery or the hope for surgery. So take hope in that, and that if they're moving forward with that agenda, and because they like to operate, as you heard, and it's true, they will not put you at risk. They will not do something that's going to harm you beyond the benefits of what they're offering. But unfortunately, less than 20% start that journey with surgery first. So usually it's the consultation, the surgery, and you don't need necessarily a biopsy at this point. Radiographically, they can determine what kind of cancer they're dealing with. And then after surgery, as mentioned, adjuvant chemotherapy for 6 months usually. And then you go on what we call is surveillance. And every 2 to 3 months you have scans and come back in to see how you're doing. If symptoms develop in that time, you come in earlier, you communicate with your team, and we see what's causing the symptoms that have returned. But the other 80%, surgery is not an option at the beginning. So you have a consultation with the team that's led by medical oncologist. You are then given options, and also based on your performance status and how well you are, and also personal choices on chemotherapy treatments. They're not a lot. However, there are some to choose from that some patients have options for. And more importantly, is when you're trying to control the disease and chemotherapy is part of making you feel better, which it will, and control some of your symptoms, there are what we call chemo holidays, and you can drive these because quality of life and living your life is just as important as being treated for the disease. So don't be afraid to, if you wanted to take a week off or go on a special trip and you're feeling better and it's something that's important to you and your family, that all can be coordinated into your plan of care safely without any risk because it's all about the balances. I wanted to bring up this slide. This is from Cancer Care Ontario, and it's about the cancer journey. And I wanted to focus on that during diagnosis, there's screening, diagnosis, treatment, there's recovery and survivorship after treatment. And along the diagnosis to survivorship or surveillance, or if you need palliative care, there's psychosocial and palliative care that needs to be part of that journey. So when teams across Canada talk about maybe wanting to refer you to psychosocial or palliative care, there is some benefit to doing that as long as you're being, along the journey as you're being treated for your disease. And I love the slide that I found about hope, balancing hope with reality. Cancer in general is a life-threatening disease. Pancreatic cancer is a life-threatening disease. However, we all live, and unfortunately, we all will die. That's 100%. It's going to happen. So at some point during your life, you need to start planning for the what-ifs. And sometimes doing this when you're well and not facing a chronic disease or life-threatening disease is the best time to outline some of your wishes, your values and beliefs, and share that with your loved ones on the what-ifs. And you don't have to spend a lot of time talking about it, but what if you were to become seriously ill and start doing some of that advanced care planning? When you're doing this in a crisis, it's very hard to do it. So that's why some of the conversation is an assessment, maybe at the beginning, is addressing some of these, and also psychosocial, and the social worker is there to help you through some of these challenging conversations if you cannot have them alone with your family. There are partners in care and partners in hope, and we're all working together to give you the best quality of life for as long as possible. So I talked briefly about psychosocial services, and these are the services that are available at University Health Network. There's individual counseling, and all cancer centres across Ontario will have basic counseling and psychosocial support. It's part of supportive care in cancer treatment. So regional cancer centers across Canada have all of these available. There's pre- and post-treatment counseling, which assists patients in preparing for treatment and coping with the side effects. Resource counseling, how you can connect with patients and the appropriate resources that you need, and medical consultations if needed to deal with anxiety and depression. Also at the center, and I've been working in this area for the last 6 months, is the introduction of palliative care services. The majority of palliative care is not about death and dying or end-of-life care. That is 10% of what they do. What they do well is pain and symptom management. Now, our team does that well as in addition to them, but we need their support, and this is how I vet it to patients and families. That early palliative care with patients in advanced cancer actually make a difference. And Dr. Camilla Zimmerman at Princess Margaret led a study that looked at quality of care with palliative care services. And actually, at the end point, which was 3 months, they didn't see a difference in the quality of life scales that they used. However, what they found interesting is the patients that were in the services and receiving some of the supports through palliative care at the 4-month mark actually had significant differences between their quality of life. So early adoption of getting to know some of the supports in palliative care, and that they can help with the pain, the nausea and vomiting, along with the anti-chemotherapy agents, and digestive symptoms. They're wonderful at doing all of that. And there are several initiatives across Canada that want to bring in early involvement of specialized palliative care, and it's a quality standard that we're aiming towards. And I'm getting to know this. This is some work done out at in British Columbia by Dr. Holly, who's a palliative care specialist, and it's the bow tie model of palliative care. And what's wonderful about this image is how it's not one or the other, it's a combination. So as you're having disease management and treatment, you can see on this side, the role of palliative care is small. It may be just for symptom management and pain. But then as treatment comes to an end, or you're going on what we call a holiday after adjuvant chemotherapy, and on surveillance, rehabilitation, survivorship, or on the other side, palliative care will take over as the options for treatment become less and less. So it's a great way of building together and merging together all of the concepts of cancer treatment together. And I'm going to be doing a little bit more reading in this area because I think it's important to talk about this and stress the importance. So there is no McCain where I live. What Princess Margaret did is took out what basic all regional cancer centers have and merge some of the support into a specialized clinic. But those services are available through different roles in different centers across Canada. It may be a nurse practitioner. It may be called a department supportive in palliative care. There may be a clinic ambulatory nurse or a nurse navigator, or for those in Quebec, I was just at our National Oncology Conference in Quebec City. They have nurse pivot, infirmière pivot, and they help coordinate care. There's social support or social work services, dietitian nutrition services, supportive care services. So look for those words within the centers that you're going to receive care in. And I actually quite like this booklet and the centers that they talk about. And they talk about in Alberta, the Tom Baker Cancer Centre. There's also the Cross. In British Columbia, the BC Cancer Agency has a lot of supportive care services. Also, CHUM in Quebec, CHUM, and McGill University are doing some interesting program development in pain and symptom management outside of palliative care and introducing palliative care that I learned about. And across in Manitoba, Cancer Care Manitoba, I've had the pleasure of speaking out there and actually visiting their center. There's a wonderful center where they give chemotherapy, and for the people outside that don't live close to Winnipeg, they have satellite areas where they give treatment, so that's great. You may have to come in for the surgery to a major regional center, but then your chemotherapy can be given closer to home. And this just is about the regional cancer centers that are available in Ontario, where you can receive care. And the question, though, Princess Margaret is a big center, and we attract a lot of business, and we're more than willing for you to come in for second opinions and find out about clinical trials. But also maintaining and sustaining hope is about your energy level and being cared for in your community. So it's something that you should consider and think about, because traveling 2 hours, 3 hours in Toronto traffic, I mean, some people can't even manage the traffic in Toronto anymore, or at some point during your journey, you may want to move forward and have your care closer to home. So how do you maintain hope? And hope, actually, there's theory behind this. Hope changes and fluctuates over time, and that's okay. Share your hopes and your dreams with your healthcare team. They need to know what frame you're coming from. To maintain and sustain your hope, you have to sustain your energy levels. So there's a lot of theory about energy banks, and in the morning your bank is full. By the end of the day, you're probably in overdraft. It's just conserving and using that energy and taking out deposits and then putting deposits in or withdrawals out throughout the day. And how do you do that? You ask for help, and you draw on offered support, including the role of psychosocial oncology and palliative care. When friends and family say, I want to help, what I can do, even for the family members, the one that's going through this journey, they say, no, I'm fine. But there's a positive for everybody in this. If you need a loaf of bread or to run the dishwasher or empty the dishwasher, it gives that person that truly wants to help you something to do, and you've gotten the task done. And a lot of people forget about these simple things that will make a difference and conserve your energy to allow you to hope and continue on your journey with treatment. And I'd like to end how I sustain myself working with patients and families. A lot of people ask, how do I do what I do? And why did I turn back to working with advanced cancer? So I turn to poetry. And I've loved this poem since nursing school, before I decided to become an oncology nurse. And it's by Emily Dickinson. Hope is a thing with feathers that perches in the soul and sings a tune without the words and never stops at all. And sweetest in the gale is heard, and sore must be the storm that could abash the little bird that kept so many warm. I've heard it in the chillest land and on the strangest sea, yet never in extremity it asked a crumb of me. Thank you.